Hello, everybody, and welcome to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association, which brings together about 60,000 Christian doctors and dentists in over 80 national movements worldwide. And today's webinar is on the subject of humanitarian response teams, principles and pitfalls. And we have Dr. Lois Fergusson to speak to us, who I'll introduce very shortly. So it's a real pleasure today to introduce Dr. Lois Fergusson, also known as Dr. Lois Morgan, and she qualified as a GP in 2013, having completed the GP vocational training scheme in East London in the UK. And from December of that year, 2013, she's worked for MEDAIR, which is a Christian faith-based international NGO carrying out humanitarian relief and recovery activities. And this has taken her to South Sudan, where I think she worked for about 7 years, also to Switzerland, Jordan, and seen her do jobs from health manager to being in the global advisory team, covering at various times programming in Lebanon, Jordan, Syria, Yemen, Iraq, and Sudan, as well as at times holding staff health and training responsibilities. She's currently on a deliberate break from employment. She's doing a 2-year MSc in public health at the London School of Hygiene and Tropical Medicine. And she's married to Alex, who is also working with MEDAIR, and I think is off to Yemen now, or fairly shortly. And she has one 5-year-old girl, Neve. So Lois, it's just a pleasure to have you here. Thank you for your time, and we look forward to hearing what you have to say. Thank you.
Thank you very much, Peter. And good morning, good afternoon, good evening to all of you, wherever and whenever you are listening to and watching this. So you've heard a little bit about me. I spent 3 years living and working in South Sudan, and then just over a year at MEDAIR's headquarters in Switzerland, and then 2 years living and working in Jordan before returning to the UK a couple of years ago. So I'm going to share my screen. This is my topic for today, to talk about the principles and pitfalls of humanitarian response teams. It's very broad, and I know I'm talking to a real range of people, both in terms of where you are from, where you might be watching from, and likely in terms of your humanitarian response experience. For those of you who are very experienced, this may be a bit basic. For those of you who haven't thought about it at all, there might be, I hope not, but there might be abbreviations and acronyms that are new, concepts that are new. Let's try to strike a balance. But please do put your questions in. I'm hoping to leave lots of time for those, as I'm sure that will be a very fruitful conversation and reflect more of where you are all at and what you want to know sort of from me. As Peter said, my experience of working in this field has all been with MEDAIR, either in or overseeing very different contexts. And all of my experiences within, really for myself, within health teams embedded in wider teams. So the examples I'm going to use are really going to be health-based, considering who I am and who you all are. But obviously there is more than that going on, and we will touch on that. And I can talk more about that with the questions and answers if you wish. It wouldn't be possible to cover every principle or every pitfall, but we will be looking today at the humanitarian principles. What are the humanitarian principles? Evidence-based responses, I'll be unpacking that a bit, but how do we really look for applying the same principles of evidence-based medicine into humanitarian crises, the best practice that we can? Looking at knowledge and experience, as a principle, you're not just trying to do some good, you're not trying to be better than nothing. What are you basing this on? And quality and measurement, again, quite broad, but hopefully with some useful things to take away from it. And going to look at pitfalls. there are lots of pitfalls. I've chosen 3 to look at protection of people from harm, to look at planning and preparedness, and reality and repetition. I am not just going to talk about the things that are difficult or that can go wrong, but also to touch on how do we try and avoid them? What does it mean to try and avoid those? So this is the actual sort of Oxford Dictionary definition of humanitarian, be either to describe being concerned with human welfare, or a name of somebody who is seeking to promote human welfare. What we're talking about today is actually going to be much narrower than that. I'm really using humanitarian to look at response to crisis or disaster. And response, so I'm talking about scenarios in which a community's own resources to cope are overwhelmed. So because you could argue that all of medicine is humanitarian, but from now on I'm going to be using it to talk about crisis response, disaster response, in that slightly more narrow sense, and as distinct from developmental work or standard health system delivery. It would be great to not need to have this conversation. It would be wonderful to be living in a world with fewer or smaller humanitarian crises as time goes on. But that isn't what's happening. In fact, it's quite the opposite. So humanitarian crises are increasing in frequency and in their scale and scope. So if you look at publications from the UN Office for the Coordination of Humanitarian Affairs, then you see every year the global appeal for funds is higher than the year before. The number of people in need is higher than the year before. This is a bit of my view of what's going on, but it's echoed across those working in the humanitarian field. So we're seeing an increasing number of crises occur. We're also seeing compounding crises. So things where multiple shocks have a greater effect than any single shock. So communities being affected by climate crisis and economic collapse and COVID, and that really being compounding effect. And we're seeing the crises being divisive. While there can be unifying aspects to responding to a crisis, actually we see increasingly that crises are driven by and then drive global, regional, national inequality. There are political and conflict consequences to those divisions, and sometimes they can be causes and sometimes they can be consequences of a crisis, and often both. So I used to say to people, have you ever had any experience of a humanitarian, of being in a crisis response? But since the pandemic, really the answer is, if you work in healthcare, is yes, to some degree you have been involved to a greater or lesser extent in different ways in a crisis response already, and maybe that some of this gives you a way to reflect some of that as well. So there are 4 founding humanitarian principles. They are humanity, impartiality, independence, and neutrality. These were really shaped initially by the International Committee of the Red Cross and the National Red Cross and Red Crescent societies. They now hold a list of 7, but these are the 4 that are broadly enshrined and accepted by humanitarian organizations. And I'm going to unpack them a very little bit, sentence about each one of these. So we're talking about humanity, the aim of saving lives and alleviating suffering in a manner that respects and restores personal dignity. Impartiality, that action is taken based solely on need. Priority is given to the most urgent cases, regardless of any other feature of that person, that individual, that family, that community, that country. That action is based on need. Independent, that humanitarian actors are autonomous. They're not subject to control or subjugated under another system. And neutrality, that humanitarian actors refrain from taking sides in hostilities or engaging in political, racial, religious, or ideological controversies. If we were all in a room together, I'd stop here and challenge everybody to think about which ones of those you think are true and which ones of those you think you have seen compromised, or if you work in this field, where would you draw the line on some of those things? So we're talking about principles. These, regardless of what expertise you bring, of where you are, that these are the principles that you're working on and under as a humanitarian. Looking now at evidence-based responses. This might sound very obvious. I've tried to unpack it a little bit on the slides, but I'll do more through explaining, I hope. So I'm talking about actually demonstrating, knowing, finding out and demonstrating, is there an emergency? And if so, what should we do about it? It sounds really basic, but actually in the same, it's a bit like taking a history from a patient in front of you. What is the story up to this point that this scenario is in front of you? And is it an emergency? So you might be trying to distinguish, is this malaria season any worse than the previous malaria season in this place? Is this something that alters by the seasons? Or is it something now which is representing more of an emergency? There are globally accepted thresholds for mortality rates that constitute an emergency, both in terms of accrued mortality rate and an under 5 mortality rate. Actually, they might not be as helpful as looking at the background mortality rate for the population you're looking at and seeing if you're looking at something much, much higher. Because reaching an absolute value might take less of a change in some countries than others from your status quo. So some of the time, is there an emergency might be very obvious just by an event that has taken place, a mass displacement of people, for example, a mass displacement of people and a disease outbreak. Yes, you have an emergency and you need a response. In others, though, it might be much harder to tell. Are these rising rates of malnutrition normal for this place at this time of year, or is this something extraordinary? So gathering information, and then what do you do about it? So in the same way that you might look at particular treatment protocols or a particular set of policies or interventions for a certain set of disease problems, a certain kind of disease demographic or population demographic. There are established best practices for certain things. Some of those sound very obvious, like if you have vaccine preventable disease and you have an outbreak, then vaccine delivery will form part of your response. But in other scenarios, it won't be quite so obvious. So who do you need? Who do you ask? Where can you find some things that help you wrestle with this? So if we're talking about how to assess, what I've tried to give is an example of a tool. And the next few slides, they're not the only things out there, but they're just an example of things that you can use. So in terms of assessing what is going on in a crisis, Usually you'll be using a rapid needs assessment. This is a combination of data sources, and they range from direct observation of health facilities to key informant interviews, like discussions with leaders in a community, discussions with caregivers of under fives, discussions with pregnant women, key people who can tell you about healthcare, illness, and norms for where you are and what was happening pre-crisis. Then these are multi-sector. This is a bit of humanitarian jargon. It's not just for the health people. It's got water, sanitation, hygiene, education, food. I'm trying to think, there are lots of other sections in there. Shelter, infrastructure. You can use the bits that you need. You might ideally be part of a team where you're looking at all of that together. These are designed for quick use in the first 3 days after a crisis. You might do desk analysis before that, so before setting off, and you might be setting off, you know, a mile down the road, or you might be thinking about a crisis which is thousands of miles away. But you're going to do some kind of secondary data analysis before you go, and then this assessment is forming your primary data analysis. It might be called any of these acronyms. With a professional background in medicine and humanitarian response, there is no end to the number of acronyms that could be on these slides, but I've tried to take them out. But all of these things refer to a similar set of documentation where you're recording what is happening in a crisis-affected community, with the aim of demonstrating both, is there a crisis, and starting to shape what does a response look like here. The hyperlink is to a page which has access to several templates. A template for doing that secondary data analysis, and several templates for rapid needs assessment if you want to take a further look. If your needs assessment says yes, there is a crisis, then your next decision will be what to do about it. And depending who you are and the situation that is ongoing, it might be what to do about it as a recommendation, or it might be what will we do about it, the organization or individual that you are in this setup. And in terms of thinking through, how do you know if what you are proposing meets international standards for a humanitarian response? Or if you're actually observing an ongoing humanitarian response, how do you know what you can hold people to or should expect? So I'm going to give about 3 slides of resources in terms of looking at this question. This is a overall humanitarian one called the Sphere Handbook, which the latest edition was published in 2018. And it brings together a lot of things in one document, which is translated into multiple languages and is available online as live to read through, as well as downloadable. It gives the humanitarian charter, protection principles, the core humanitarian standards, which are standards that an affected community can expect to be able to hold humanitarians to, and minimum standards of response for water, sanitation and hygiene, food security, nutrition, shelter and settlement, and health. Within the health piece of response, there are kind of six pillars. I'm not going to be able to remember all of them off the top of my head, but it would give you a framework for looking at and thinking through, for any affected community, what are the impacts on maternal and child health, communicable diseases, non-communicable diseases, mental health, health system strengthening. And within each of those, there are minimum standards that a health response should meet, and the same for other sectors. That link will take you to a kind of parent page from which you can have a look at that resource, and whichever section of it is relevant for you and those around you at the moment. In terms of where would you look for health evidence or health resources, I think I'm going to give 2 suggestions of places that I would go to, but that is with another principle maybe before that point. You have a choice as a humanitarian health response team. You can operate inside an existing system, or you can set up a parallel system. My experience is with MEDAIR, and we would very much be aiming to operate within a health system with the aim of actually equipping it better to be able to respond to the current crisis and looking forwards to make it stronger for the future, to avoid the duplication and the waste that comes with having parallel systems. And there are situations where maybe that wouldn't be the case, but they're very much the exception rather than the rule for MEDAIR. Other agencies operate differently, and it varies from context to context. Ideally, you'd want to be using a country's own guidance, but in some places you won't have any. So in South Sudan, when I was there, we couldn't rely on the national primary care guidelines because they didn't exist at the time. And so you have to have a way to then be operating as an international NGO, being held to international standards. So one place I would go to would be looking at WHO resources. There would be, there'd be an endless list of things that you could use, but there are clinical guidelines, hospital pocketbooks, policy guidance, things that you can use either as they are or consider adapting. Things like essential medicines lists, which are very useful when you're considering what do you want to have. And they have pre-packed kits for different scenarios. I've given 2 examples here of sort of more specific things and also things that I have found very useful. So one is a mental health resource and one is a disease outbreak resource. Just if people want to have a look, I'm sure you might have more specific questions on either of those, but just to signpost a couple of things that are useful. The other set of resources which I would point you towards, if you're in a scenario where you don't have an adequate set of country resources, what do you look at? MSF have sets of medical guidelines available online in multiple languages, clinical guidelines and essential drugs, which are also supplied by WHO in kits and within responses, and then some disease-specific guidance for dealing with particular outbreaks. They also have app-based versions which get live updates, which is great. You have to wait for something to be reprinted. And then looking at knowledge and experience. You need some knowledge and experience, but of what? So I've got some suggestions. Humanitarian response, health and/or nutrition expertise, depending on what you're going into. You might need some other people if you think you're going to need to construct things. If what you're constructing needs a water supply or has really specific water needs, like a cholera treatment unit. You might need people who can work in other modalities, so providing cash or voucher-based assistance rather than actual delivering healthcare. You might need specialists, and you might need people who can do a lot of other things, like write grant proposals, write reports, manage your security, coordinate a project. You're also going to need some people who know about where you are and who you are serving. And they will know a whole set of things that if you are coming in as an outsider, and there are lots of different ways to be an outsider to a scenario, you need to consider what you need to know. So you you really want to know this disaster affected community, wherever they are, whoever they are, they have pre-existing knowledge, attitudes, practice, coping mechanisms, and you need to know what they are to be able to shape a response for them. And you want to know what you've done. What have you done? How much of it did you do? How many people did you reach? Did it make any difference to them? And that might be a quantitative difference. You might do a population survey. You might do a vaccine coverage survey after a campaign. And it might be qualitative. What did it mean to receive aid? How did it feel? What did it mean for your family that this was the pregnancy or delivery care that you received? And could they tell you what they thought about it? So we've looked at on what do we stand, what do we do, where do we do it, when do we do it, who does it, what have we done, how well did we do it, with what impact. And we're going to look at how we could get it wrong. And in between is this one slide, coordination. It's not a pitfall, even though it can sometimes feel like it. And it can, I guess it could be a pitfall. But actually, in a humanitarian response, there's going to be an enormous amount of coordinating with other people, with agencies who oversee everybody, with other people who are trying to do exactly the same thing as you. And you're going to need to have a lot of conversations, and it's really vital to do it well. And so those were just examples of meeting titles. You can ignore all of them. It was just to demonstrate how many there are. And that's definitely not all of them that you might be expected to be at as a team working in one place in several sectors. How could we get it wrong? I think there are lots of ways we can get it wrong, but I think one of the biggest ways to get it wrong is by never thinking about it. So by thinking through how could we get it wrong, challenging those things and talking about those things openly as a team is a great place to start. So protection concerns, safeguarding the vulnerable. In a crisis, especially a displacement, but a lot of people at a lot of risk. You may be attending as a humanitarian team and wanting to provide aid, but there are lots of other people who might see this displaced population as an opportunity in an extremely different way. So considering particularly unaccompanied minors, people with disabilities and people with mental health conditions. So people who are affected differently by the crisis and also may have different access to the assistance and the response. And people trafficking as an active concern, particularly people crossing borders, and the vulnerability of those populations. So it's vital that people affected by a crisis have access to accurate and timely information, and that every action you take, you consider how you could put people at risk of further harm within it and try to avoid doing those things. What should you plan for and how can you be prepared? So you might be working in a setting where you do have frequently occurring crises, or you might have. So what does it mean for you, your setting, your clinic, your hospital, your region to be prepared? You might just be thinking, if I went and left my home country or my passport country or my working country and went somewhere else, what does preparedness mean? So I would say if you're thinking through what could we plan for, I'd say look at what has happened where you are, what has happened already. Have you had disease outbreaks in the last year, the last 5 years? What of? When? Are you in a natural disaster prone area? Oh, sorry. And are there potential displacements? I know that not everything can be planned or prepared for, but I would say if you're trying to think through, for example, you manage a hospital and surrounding community services, can you sit down once a year and think, what are the likely crises where we are and what would we do about them? So essentially what we're talking about with how can you be prepared is resources of different kinds, human, financial, knowledge, based, but how can you be prepared? What human resources do you have at your disposal, and what experience and expertise do they already have, or could you equip them with? And for want of a better way of describing it, I've called it criticality. If you had to spare some people from your normal everyday activities to respond to a crisis, who would it be? And are they the people with the knowledge and the training? It might not be who you expect. So trying to think that through, and how long could you spare somebody from their day job or their regular work to be able to respond? Are you prepared in terms of information? Do you know where you would get resources, sources of information? Be they technical or outbreak based? Are you carrying out disease surveillance so you know if something happens? Would you know who else to talk to if there was an emerging crisis? And do you have supplies? In several of the places that I've worked in or covered, there are outbreak-prone diseases that occur. And actually, you don't want to have to go and find, go to the back of a warehouse and find the things that you haven't needed since the last rainy season. You want everything all together. So do you have a cholera box? Can you crack open one thing that lets you do the first 24 hours or thereabouts? Yeah. And reality and repetition. So I think that many of us will be familiar with the idea that there are upstream determinants of health and downstream determinants of health. So things that actually act as causes to poor health developing, and then your downstream determinants of health, including things like your access to healthcare for when you are ill. I've chosen a cholera outbreak because I think it's a good example of a pitfall, if that's the right way to think about it. So in a cholera outbreak, what you would like to do is stop it happening. You want to go to those upstream determinants of health and stop them occurring. So provision of safe drinking water, total community sanitation, hand hygiene. Obviously, we could make a much bigger arrow here, but they were sort of the first three things that sprung to mind. And obviously, those first two, if you had those, you could prevent the cholera outbreak from happening. But once it's happening, what you're looking at are your downstream determinants of health. So risk communication, community engagement, talking about case recognition, hand hygiene, access to treatment, your provision of treatment, thinking quality inpatient and outpatient treatment, and potentially cholera vaccination, which could be single dose ring vaccination if speed is of the essence, which it usually is with cholera. What you want to be doing is both of those things together. Sorry, I couldn't remember whether I had a slide with both on, but I don't. Ideally, you would do all of that. What you might find is that, let's say you're receiving a grant, the donor might be very willing to fund the downstream response, but they might not be as willing to fund the upstream prevention. So without that, you are going to end up in the same place doing the same thing over and over again. Hence my comment of reality and repetition. These are my suggestions and things I have seen work in practice and we have done successfully, but to try and avoid that. So when you're responding, you need to embed prevention in your response. You need to embed preparedness in your response. You need to consider things like disaster risk reduction. In humanitarian circles, this might get talked about as building back better. And it has really moved from being seen as quite niche to being absolutely vital, that emergency preparedness and response are all together, preparedness and response, and reducing risk. So for example, if you're working in a location that has cyclones every year, that if you're building back, you need to be building back something that will last beyond the next cyclone season, however, whatever that might mean. It's much easier to envisage with shelter maybe than healthcare. But health system strengthening would be an example of this for me. So when, let's say, you run a response to your cholera outbreak, and that includes all rehydration points at local primary healthcare centres and support to the hospital with inpatient cholera treatment. When that finishes, can you leave all of them as locations and as people, staff, better equipped for the next time that happens? And I mean, the answer should be yes, and we really need to be aiming for that. And feasibility, being honest and transparent. If you are a humanitarian response team, you need to be honest and transparent about what you are able to do. And if you are not a humanitarian response team and you might need the help of one, you also need to be able to be honest and transparent about what you are able to do. So in terms of the pitfalls, we've been thinking about who is the most vulnerable and how might they be exposed to further harm actually within this response. Are we ready? Should we be ready? Are we ready for the right things? What can we really do? And how can we not have to do it again? Because as I said, it'd be nice to not need to have this conversation at all. It would certainly be nice to not continue to respond, continue to have people exposed to the same sets of risks and crises, if that is feasible. I think everybody will get the slides maybe as a PDF, and there are some other resources beyond this point that I have put in there, just in terms of if you want to look at some other online resources for learning about particular settings, and I'm afraid they are a bit global north. So they are links through the London School of Hygiene and Tropical Medicine, and also to have a look at the Johns Hopkins University Centre for Humanitarian Health. But they're both really good hubs of evidence, both sort of generating it and interrogating it and reporting it. So if you are in this, their newsletters are good sets of things to get to kind of keep your finger on the evidence pulse. And if you're not sure if you want to be in it, then they're good things to have a look at to help decide that as well. But other than that, I am going to turn my sharing off so that Peter can ask me some of your questions.
Thanks very much, Lois. We've been listening to Dr. Lois Fergusson on the subject of humanitarian response teams, principles and pitfalls. We've now got time for question and answer. So Lois, I wonder, first of all, if you could just give us a brief sketch on MEDAIR, the organization you've worked with, and its size and scope and areas of work and the kind of emergencies it responds to, just to give people a little bit more context on what you've been saying. Thanks.
Sure. So I have worked for MEDAIR, it's a Swiss-based international NGO with a Christian foundation, and we are working currently in Afghanistan, Madagascar, Yemen, Syria, Jordan, Lebanon, Somalia, Sudan, South Sudan, DRC, Ukraine, Poland.
And you're working in all of those places simultaneously at the moment. You've got programs in all of those places currently.
Yeah. So we have established country programs in those places. So that means at some point in time, and it varies enormously, obviously, with our shortest lived country program being Ukraine at present. And I'm not sure which would be the longest, but certainly this year we've been in South Sudan for 30 years.
Yeah.
So it varies enormously, but at some point in time, there has been a crisis which has led to MEDA being present there, and there being a kind of entry and launch decision made.
Yeah.
And then within some of those countries, we might have additional flexible emergency response capacity. So we might have established field bases and teams that are working on projects that they already know will last a year or 2 years. And then there might be other teams within the country program who are looking at an acute crisis and responding to those. Scale, I think MEDA's annual turnover is something in the $85 to $90 million. So we're pretty small for an international humanitarian NGO.
And how many staff would you have on the
staff
in the team? Yeah.
Yes, that is a really interesting question, and I'm not sure I know the answer at the moment. We have a headquarters in Switzerland, and then all of those country teams and some regional support staff, and we have about 10 people serving in their home countries for every one person who is serving outside their home or passport country. And I have a feeling it's somewhere in the 140, 150 international staff,
Yeah.
but that's, and 10 times that in people who are serving in their own countries.
And how is MEDAIR funded as an NGO with a Christian base? Is it, doing a huge amount of work? How are you funded?
So MEDA is predominantly institutionally funded. So that means most of our money comes from government or multilateral bodies. It's not private funding, as in it doesn't come, the vast majority doesn't come from individuals. So about 85% of our money comes from institutional donors, which means, by which I'm really meaning people like ECHO, which is the European Union humanitarian grant giving organization, the Bureau of Humanitarian Affairs, which is the US government funding, what we used to get money from DFID in the UK and now from SCDO. So those bodies and things like humanitarian pooled funds within countries, and that's where sort of the vast majority of the funding comes from. And MEDA has Christian foundations, but not all of MEDA's staff are Christians. We work in locations where that is not feasible. It's not something that we hide. Every agency has a worldview. We're very honest and open about ours, but that doesn't mean, like, MEDA doesn't proselytize at all. And so, yeah, I think just to be really clear on that, I know that is not everybody's cup of tea, and other agencies do it differently, but that is MEDA's stance.
And has that created any problems for you, being a Christian organization? Do you encounter any prejudice or suspicion particularly from multilateral or institutional funders because of that?
I'm sure that we do. I think the kind of hand on heart honest answer would be those are not conversations that I have been in, kind of from the roles that I've done from within MEDA. And that's not, I don't mean to dodge the question. It's more I don't have first-hand experience of that. I'm sure that does happen. I think the dialogue around community-based organizations and faith-based organizations can be something that's very divisive, but equally actually having a worldview and a faith-based worldview is not unusual globally. And so actually being able to hold conversations which involve faith is not a bad thing, and doesn't necessarily make you difficult or bad at what you do, I think for Med-Air, you know, we're not engaged with bringing, you know, with telling people about Jesus, or sharing the gospel in that way, and we're very, very clear about that. And given many of the contexts we're in, you can understand why.
Michael Back from South Africa is asking, how do you decide where to go? And you know, he gives examples: Tigray, where there's civil war; Somalia, where there's a lot of malnutrition or a failed state. Are there any disasters you won't go to? A bit more on the principles of how you decide where to deploy your staff and resources.
Yeah, great question. So I have mentioned where we are. They're not the only places in the world with crises. They are a lot of the largest. And in terms of decisions to go, I think I would think about it two ways. So one of them is when we're thinking, do we go to a new country, somewhere that we're not, and set up a country program? So we have a global emergency response team. So a small number of people who are looking at basically global data. So we're monitoring, you know, weather predictions, outbreak alerts, looking at trends, engaging with what is kind of context analysis globally, what do we think is coming, and looking at and then they would be the team doing the kind of secondary data analysis, as it were. You're not there. What do you know about this? What is happening? And what will it take to go? So there would be a meeting within Med-Air of a group of people who would act as a decision maker to send. Are we going to send the emergency response team? Would be a kind of first piece decision, and then they're there, and they would then decide. Are we going to stay and respond? Are we going to do a short scale response like post a natural disaster? You're going to do some kind of response that lasts 3 to 4 months that meets shelter and water needs. But actually that's it. Once that's done, we're going. A lot of it. So some of those decisions will be based on existing coping mechanisms and existing resilience within a country that's affected. So is it reasonable to expect that country to cope with this crisis by itself? In which case we wouldn't go. And then if it's not, so it is going to be a humanitarian crisis in which a government cannot meet the needs that will exist, you're really looking for an overlap of needs, your mandate, your organizational mandate, and funding. So what do you have available to go with? If you have nothing in your pocket, then setting off is not a responsible thing to do. You know, if you know, actually, we've just launched another country program, we've got, you know, we've used lots of rapidly available staff to launch this, we can't go somewhere else as well, then we shouldn't be setting off at all. So you're looking for the overlap of those pieces. And in terms of sort of health and nutrition triggers, you're considering disease outbreaks or rising malnutrition. So for instance, we now have a team in Kenya because of the drought and the subsequent malnutrition crisis in the Horn of Africa. We already had teams in some of those locations, but not all. And now we also, not sure from exactly when, but in the last few months have a team in Kenya providing nutrition assistance. So some of it is looking at those trends. I'm not sure whether that answers exactly the question.
Well, that's really great, and it's a good big picture overview of it. A fairly quick specific question. This is from Shari Falkenheimer, who heads up the Medical Education International, which is part of CMDA US, one of our member bodies. And she's asking, what do you mean by total community hygiene? I think you talked about, for example, in preventing cholera.
Do you know, even when I put that in, I thought I definitely should have run that past one of my WASH colleagues, because I actually think it's think it might be, I might even not have the term correct. Looking for a term which encompasses not just the provision of hardware like a water supply and maybe construction of latrines or repair of sewage, but something that also encompasses the hygiene, so the behavior aspects of it. So it should be something that involves infrastructure and behavioral interventions going hand in hand, not just one or the other, I think.
Now, Medair, people hearing it might think, you know, you're an Air Force, you know, but like Mission Aviation Fellowship or something. Is movement of patients by air part of what you do?
It's not. It does sound like it should be. So Medair was founded 33 years ago by a combination of people out of MAF, Youth with a Mission, and medical logistics. And overnight, they had to come up with a name and called it Medair, and we've never looked back. But no, we generally don't fly patients around. We do work very closely with MAF in several of our country programs, but they're definitely always doing the flying, and we're rarely flying patients.
Now, I'm sure people listening to this and the window you've opened up into your work are thinking, wow, you know, I'd love to be involved or available for things like that. Is there a scope for short-term volunteers? Do you have a list of people you can mobilize? How can people get involved, you know, either as staff or being called upon with their expertise to help?
Definitely appreciate that question. Yes, we do have a list of people who our global emergency response team can call on if they know they're looking at a go very shortly. It may not surprise you to hear that most of the time what we're looking for are people who've done it before for those kinds of roles. But one of the big strengths for me about Medair in my personal experience was that I only needed my professional skills to get my first job with Medair. I didn't need to have humanitarian experience before that, but I needed the medical piece all in place. In terms of specific requirements for Medair, the website has lots of information on it about the types of jobs we have, the sorts of skills we're looking for. We're often looking for generalists. We do primary healthcare and public health-based responses. So we're very rarely looking for surgeons or anaesthetists or specialists. We're looking for generalists and for people who kind of are a attitude and values fit as well as a professional fit. We do have a short-term roster. It's usually populated by people who have worked for Medair before, and those kind of regular contracts are usually a year starting, so they're not it's not, you can't sort of usually drop in for 2 or 3 weeks, although in those really hyper acute disasters, yes, we are looking for people for 2 to 3 weeks at a time.
And do you deal with volunteers as well as people you take on in a paid capacity? And subsidiary to that, what would be the range of duration for volunteering?
Yes. In terms of going outside your home country into the field, no, we don't have volunteers, we have staff. In terms of can you volunteer for Medair on a kind of representation and speaking and talking, yes, but that's usually not, that's often not what people are asking about. From a can you deploy and do hands-on work, we do have volunteers. They're usually from the disaster affected community, rather than being sort of taken into places. Just to say though, all of that really varies between humanitarian response agencies. So if this is something you want to think about, I would look at other people, whether they're people like Samaritan's Purse who have a faith-based and different approach to what that looks like in the field, or whether they're not. So MSF, what does it look like to go with them? Because they and MEDA and, you know, International Medical Corps and the Red Cross, the British Public Health kind of response register, they're all incredibly different and looking for really, really different people. So thus far, my experience is working for MEDA, and so I can speak with great authority about what we're looking for, but actually, this is one of the things where what agencies are looking for will vary hugely between them, because what their mandate is different. So people like International Medical Corps are often providing specialists. So depending what you can do, MSF have much more hands-on medicine delivered by people who are not in their home countries. So there are real differences between how agencies deploy you. So if you want to be doing that, I'd really encourage you to have a look at a wide range of humanitarian agencies, because what they're looking for is really different, and what they deliver is so different. Yeah.
Just a final question, because sadly we've run out of time and there's a lot more we'd love to be asking you, but this comes from Howard Lyons, who's one of our ICMDA board members with a huge international experience in healthcare management. And he's saying ICMDA members inevitably want to respond to global emergencies. You know, we're a great big Christian family, and we're praying for each other. We know what's happening. I could give you a dozen disasters that have impacted one or more of the organizations. And so we do have a disaster response policy. And normally this involves simply channeling resources and assistance through established agencies, both Christian and secular. But this year, because the Christian Medical Association in Ukraine was very well placed to receive and distribute resources, we did more on that. So his question is what, in your view, would be the best way to safeguard and nurture this expertise for future emergencies, whilst not deflecting ICMDA leadership and others from their key mission of starting and strengthening national movements? I guess, yeah.
Okay, I'll have a go off the top of my head, but if anything else comes to me, I'll drop you a line later. I do think that ideally you would have those pre-positioned national contacts, and so actually being able to channel aid through known agencies in Ukraine is brilliant. Like that, I think that's great. I think in terms of how do you try and safeguard, nurture and safeguard expertise, I don't know whether there's any way to do any kind of sort of reflection or an exercise with people who that involved about how did that go? Did it work? Do you know, did it work? That's a very vague question, but but you know, actually, can you sort of gather the successes and as well as the things that weren't so successful about doing that? But that's a great way of doing it. Is there a way to kind of set up, actually, if you know you've got however many countries you have gathered within this organization, can you almost do a kind of crisis mapping exercise of, okay, if there was a crisis here, do we know who we would fund in, I'm not sure, but do you know who you channel that through? Could you have a point of contact? You know, so actually if you had, I do know that one of the health advisors for MEDA in Ukraine spoke with, using exactly this network and setup, was able to speak with somebody who could tell them much more than had they not been able to do that. So using contacts, being able to share those contacts with agencies who are arriving, if they're new, being able to use that contextual knowledge. Maybe having, is it possible to just hold kind of contact details for the sort of humanitarians within ICMDA? I don't know if that's realistic. That might be just enormous. But like within the UK, the CMF have kind of got a bit more of the kind of the international arm to help people with that those global jobs and views and things to contact each other, is there a way that you could have a kind of humanitarian network? So actually you could put feelers out. There are Christian groups of agencies as well. That might be another thing to think about from an ICMDA point of view. The Integral Alliance and the START network. I'm sure about Integral Alliance. I'm not totally sure about the START network, but Integral Alliance is a group of Christian NGOs, and actually if there is a large crisis, there'll often be discussions within that group of NGOs about who's already there, who might go, who knows contacts and agencies and things. That might be another thing just worth sort of thinking about, offering contacts through or to.
No, that's a brilliant pronto response off the top of your head, and really, that gives us a lot to think about, and I'm sure that Howard Lyons will be on the phone to me or before too long. Lois, thank you so much. We've been listening to Dr. Lois Fergusson on humanitarian response teams, and it certainly opened a whole lot of new thinking for me, and made me aware of a lot of things I wasn't aware of before. But we're hugely grateful for your time and expertise. May God bless you in your work and in your future direction as well. I know you're looking at different options, and I think that the quality of and the number of the questions is a good indication of how stimulating this talk has been. So thank you very much, and thanks to all of you who've come along today and made this a success. May God bless you, and we look forward to seeing you again soon on ICMDA webinars. Thank you.